Thank you, Ms. Tanner. Ms. Tanner, has today's school board meeting been properly certified?
Yes, it has. As of December 27, 2020, notice was provided for full and all criteria of VA Code Chapter 37.
Okay, thank you, Ms. Tanner. I duly call this meeting to order. Ms. Tanner, please proceed with the roll call.
Yes. Basine,
Here.
Campson,
Here.
Blanton,
Present.
There we go.
Gabriel,
Present.
Gordon,
Here.
Smith. Smith, is she frozen?
Oh, no, she was here.
Well,
There
she's right
she
there. I was
is.
about to say, wake up, Christine, but I think she's frozen.
I think she's frozen.
How do you unfreeze her?
Okay.
I don't see her.
Yes,
She was
she's
definitely here.
She's right there.
She's there.
there. I think
She's on mute.
you just got jumped out. Oh, no, she's
Are you
there.
sure?
Yes, she checked in.
Okay, I see her. There she is. Okay.
Okay. And Martin,
Here.
I'm going to come back to Christine, even though we see her here.
Christine.
That was a good idea.
I like those. Those are cute. Christine?
I'm sorry, I didn't. You know what? I am so sorry. My sound was down. I'm working, multitasking.
You're a busy lady.
Well, I
But
just
you're
called
here.
her home, so
Okay, thank you so much. Okay, well, good evening, everyone. We have a very busy meeting tonight, so let's go ahead and get started. At our September 16th work session, the NPS administration provided a briefing on the opening of the 2020 fall semester. The NPS leadership, principals, teachers, and staff continue to do an excellent job providing a high quality and engaging learning environment for our students. We have heard from many parents, guardians, teachers, and community members who have shared their stories. Thank you for reaching out to us. Since the school board meetings are also held online, we are accepting written public comments. They are posted online at the NPS board docs page. We do read them. However, as a policy, board members do not respond to public comments. Tonight's meeting will be in 3 parts. We will begin with a workshop where we'll hear from Dr. Demetra Lindsay with the Norfolk Health Department. Then we'll go into our executive closed session where we'll disappear into a private Zoom room. But then we'll be back, we'll return at 7 p.m. for our business meeting. I know there are a lot of parents and community members who are tuning in specifically to hear Dr. Lindsay's presentation. So I will hand the floor to our superintendent, Dr. Sharon Birdsong, to make the introduction. Dr. Birdsong.
Good afternoon, Madam Chair Martin, Vice Chairman Jordan, members of the school board, and members of our community. Thank you for the opportunity to share a few thoughts with you today before we move into our workshop agenda. We are a little more than 3 weeks into our unprecedented school year. Much work has been done and continues to be accomplished as to ensure a positive virtual learning experience for our students. All of our teachers, administrators, and families have been working extraordinarily hard to ensure that the learning process is going smoothly and students are transitioning well into the school year. The school board's decision to reopen schools virtually during the first 9 weeks of school was a decision that kept the health and safety of our students and staff foremost in mind. In fact, our school board led the way in the region in making a decision about how students would start the school year. And if you have followed previous board meetings, then you are aware that this was an extremely challenging decision for the school board to make, and one that involved a variety of complex issues. Upon receiving this direction from the board, the administration and staff worked tirelessly to develop a robust virtual instructional plan for the first 9 weeks of school. The board requested and then received information regarding the administration's implementation of this virtual plan and other pertinent information during the most recent school board work session. As I shared with the board, I believe that our smooth reopening of schools demonstrated the magnitude of our talent, skills, knowledge, and abilities to do whatever it takes to ensure the success of our students. Even during this challenging and stressful time, I have been amazed by the extraordinary teamwork that has been demonstrated by our internal and external stakeholders to support our children and families during this first 9 weeks period. Our second quarter of school is right around the corner, and it begins on November the 4th. Many of our parents are asking what our school division has planned for the second 9 weeks of school. Prior to the start of the school year, when the administration was working to develop plans for implementing a virtual learning platform for the first 9 weeks of school, we did not do so in isolation of planning for student learning beyond the first 9 weeks. As educators, we know that it would be nearly impossible to plan for one 9 weeks period and not subsequent grading periods. Additionally, the administration knew that at some point our students would be physically returning to school buildings for in-person instruction. As you can imagine, the logistics are extremely complicated for implementing in-person instruction during a pandemic. However, the administration is prepared to present a plan to the school board as scheduled during the work session on October 7th. Of course, logistics for returning students represents just one piece of the decision-making puzzle. Another big piece of the puzzle involves the health metrics of our community. We are so fortunate this afternoon to have with us Dr. Demetria Lindsay, who serves as the Director of Public Health for Norfolk and Virginia Beach. Dr. Lindsay will review a variety of health metrics with us, as well as discuss the presence of COVID-19 within our community. This information will be vital to the school board to consider as they make the decision regarding the return of students to in-person instruction. Dr. Lindsay earned her Doctor of Medicine degree from the Duke University School of Medicine. She completed her internship and a residency in internal medicine at Washington University Jewish Hospital of St. Louis, Missouri. Dr. Lindsay is board certified in internal medicine, and she's a graduate of Clark University in Atlanta, Georgia, where she earned a Bachelor of Science degree in biology. So without further ado, I would like to welcome to our meeting and to introduce to you Dr. Demetria Lindsay.
Good afternoon. Can you hear me?
Yes.
Great. Thank you so much for this opportunity to speak to you. It is a pleasure to the board and parents, as well as the community at large. I hope that you find this information useful in helping you to understand some of the dynamics of what has been going on in our community, as well as to help inform your decision making for a very important sector of our community, and that is our children. So I want to start with the first slide, but perhaps I should frame this a bit by saying that I felt it was important to kind of make sure that we were all on the same page in terms of having some background of what has gone on in terms of COVID in our community. So I am starting with a bit of history and moving from there to sharing with you some of the data that we have been tracking in public health from the health department that will evolve looking at community transmission data, moving on to data for not only our region, but also I've spliced in some locality data, and then ultimately some of the most recent data and recommendations coming from the health department and from the Centers for Disease Control. So to start with, what you see before you here is just an epidemiologic curve looking at the course of COVID-19 in the city of Norfolk. And it starts way back in March, which seems like so long ago with this pandemic, but actually it was not that long ago. We were fortunate in Norfolk that initially we did not have a lot of cases. as we began. But as you can see, in the course of the infection, it did start to rise. March 16th, or around that time, a little bit afterwards, represents the time, around the time of the stay-at-home order from our governor. And if we were looking at measures for the state and region, you would see that we were experiencing higher cases here, and we did see a decline after that stay-at-home order. But we started out fairly low in Norfolk. And then the markers that you see, the vertical lines in red, represent dates at which dramatic interventions were made to try to limit the spread of the infection. So just prior, the next line or marker was the introduction of phase 2 restriction, phase 1 restrictions, and then phase 2, phase 3 restrictions. And you might notice that with those restrictions or actually openings, we did sort of see a slight rise in cases. So to go back and rephrase that, we had restrictions in place, and as we began to relax them, we started to see a little bit of a rise in cases. And the interesting thing, probably even more apparent with phase 3, is that as people began to anticipate an opening or relaxing of the restrictions, you began to see a rise in cases. And so for some members of the public, the message may have been misunderstood that this is something that is about to go away, and we have more opportunity for freedom, and with a relaxation of those important preventive measures, such as masking and social distancing, we begin to see a rise in our cases. So around phase 3, in late June and early July, we saw our most dramatic rise in cases in our community. And this is what we call the surge. This occurred mainly in the urban parts of our region, not just Norfolk, but all of the larger cities started to experience this. And that dramatic rise was finally, it resulted in the need for putting something in place to blunt this. We did not want to see this continuous rise and associated deaths and adverse outcomes as a result. And so then with the reintroduction of some restrictions, we start to see that curve fall down to kind of where we are now. 9/6, a release of those restrictions that were placed, and then a slight rise. It's a little hard to say, it's a little early to say, but fairly stable, and we may be seeing some decline there. So moving on to the next slide, please. Spend a little time on that one. I'm going to share with you some demographic characteristics of cases that we've seen. Some of those are, most of these are cumulative cases, but it do reflect a trend over time that we have seen with COVID-19 in Norfolk. This represents something that we saw very early on, just at the beginning of the surge that I was speaking of. If you look at that third block of cases, and this is the number of cases, and it's separated off into age groups. In that third block, there's this dramatic peak of cases, the gray bar, in the 20 to 29-year-old age group. We also see a significant increase in the 18-year-old age group. And that is significantly high in comparison to the representation of those age groups in the population. We also, at around this time, had the benefit of having done many case investigations. That's any positive case that's reported to us, we interview and we try to understand what is going on with that person and those activities and risks that may be involved, and anyone that they may have come in contact with who could be at risk of contracting the disease. What we observed was a pattern among our positive cases and also many of our contacts with those cases that we were seeing a large number of social gatherings in the community, many private gatherings in homes, Father's Day celebrations, birthdays, graduations, backyard barbecues, and felt that that was significantly contributing to this. At the same time, we were also observing in our public health investigations, particularly among businesses in our business investigations of food service areas, that in bar areas of restaurants, we were encountering huge gatherings, as much as hundreds of people not wearing masks and not social distancing. So we felt that those things were critical in understanding what was driving this increase in cases. Was largely young adults impacting our rates. The concern is here that although young adults may not have significant adverse outcomes, and they do have some, as this passes to the next generation and the next generation who acquire disease from these individuals when they come home and they go and visit their families and their grandparents and whoever else, eventually this ends up impacting individuals who are at risk for serious complications. And that's when we start to see the rise in hospitalizations and deaths. So that was a big concern to try to blunt this, to prevent ultimately innocent individuals who have nothing to do with the activity that was causing this, suffering the outcomes. So next slide, please. And here, it's another way of showing you that dramatic rise in cases among specific age groups. And that top kind of beige, orangey beige looking bar are the 20 to 29-year-old age groups. And you can see how dramatically it went up in comparison to others. The other is 30 to 39-year-olds. So the majority of our cases suddenly were cases under 40 years of age. What you see in the next slide is kind of a breakdown of cases by age and race. And what I wanted to point out here to you is that in all of these age groups, the beige bars represent the African American populations in those age groups. And by far, a significant proportion in each age group, or most of these age groups, were African American. Next slide, please. And to carry it even further here, I'm showing you the percentage of cases by race, and over 51% of cases at this point are African American. This is actually down from much higher in the 60s and almost 70%. To the right of that is the distribution of cases by race compared to their representation in the population. So African Americans represent 42% of the population and currently 51% of cases, whereas whites represent 44% of the population, but only 19% of cases. So we see a very disproportionate representation of African Americans in terms of who has been impacted by COVID-19 in our community. And next, I want to talk a little bit about adverse impacts of this disease. So next slide, please. Here we're looking at hospitalizations, and you can see the curve of what has happened with hospitalizations since April. It has come down significantly, but we're starting to see a rise here, a gradual rise. Remember, our surge was in late June, July, but we're kind of seeing a rise here, July, August, and it is possible that we're seeing some delayed effects of our surge there. Also want to point out to the right in terms of just putting this in perspective, most of our cases don't end up hospitalized. 92% are not, but we have about 8% of our cases that end up with hospitalizations and a little bit under 2% of deaths. Next slide, please. And here, who is adversely impacted in Norfolk communities from COVID-19? Again, 71% of hospitalizations are in the African-American community. And as you can look to the left, as we break this down by age groups, in the younger population, among children and young adults, even more dramatic, 10 to 19-year-olds, of those hospitalizations that we've recorded, 100% of those hospitalizations in 10 to 19-year-olds have been African-American, 75% in 0 to 9 age groups, and still dramatically larger representation among most of the age groups here. Next slide, please. And this is represents case fatality, and many of you may be aware in the literature that seniors, with a rise, about every 10-year rise in age, we see an increase in risk of death. And here, that corresponds with what we're seeing in Norfolk in terms of death rates. Who is most likely to be affected? It is the elderly. And particularly, we're concerned about elderly in congregate settings such as nursing homes and assisted living facilities. They may not even have very many obvious symptoms of disease, but could still experience deaths. And also added here for you the stratification by race. And again, the vast majority of deaths are in the African-American population. Next slide. So in summary, just talking about the health impact of COVID-19 that we've seen in the Norfolk community, African Americans and the elderly have been most adversely impacted by COVID-19, representing a significant proportion of those who are hospitalized and higher rates of deaths. We did experience a recent surge, which was characterized by dramatic rise in cases in those under 40, particularly those in the 20 to 29-year-old age groups. This was largely driven by behavior, patterns of lapses in preventive behavior, gatherings around bars and restaurants, and club-like areas of restaurants, and also private gatherings for private celebrations. So you may hear me repeat this in different forms again and again, that human behavior matters. It's difficult to predict. It's a choice that we all make, but our choices impact not only our lives, our families, our loved ones, but it impacts our community. And our choices and our ability to safely have our children return to school is significantly impacted by the choices of behavior that we make. Next slide, please. So I want to talk about some of the metrics that Virginia Department of Health looks at, and most of these are available to you, to the public now, that you can look at online. I've spliced in here the link for these measures. Basically, at this point, we have two levels of measures. One are the community mitigation measures and also CDC metrics. So looking at our community metrics, I will show you our daily regional metrics, and these are designed to show, pretty much give a sense of where COVID-19 is spreading and how it's changing over time. And then secondly, the weekly transmission is designed to help inform potential mitigation strategies. Next slide, please. So first, let's look at the daily regional metrics. And next slide, please. Forward facing, these are looking really at regional data, but I have spliced in here some local data for you also to be able to see this evening. So this is, if you go to the website and you select that tab that I just showed, it will take you to this area. You have the opportunity to select the region, the date that you want to look at, and also the type of graph. And the major ones that we tend to look at are burden and trend. So this is giving us an idea of the burden of disease in the community, as well as the trend, whether we're seeing cases increasing over time, whether they're decreasing, or they're fluctuating or staying about the same. There are 8 metrics that are included in this area, and these are daily case counts, daily case incident rate, PCR, percent positivity, the rate of outbreaks, percent of cases in healthcare workers, the rate of visits to emergency visits, and you can read the rest there, but those are the major ones, I think, that would be of concern today. Next slide, please. And so here, just to break that down, these metrics give us an idea of disease burden, our most recent rate, and it has a graph, and each daily measure gives us a measure based on a 7-day moving average. So that's designed to just kind of smooth out the bumps and lumps that kind of come about with some variation of the time that we receive the reports, and just sort of help us standardize for comparison's sake. The second piece is the trend, and again, as mentioned, increasing, decreasing, or fluctuating, and we're evaluating or comparing this to change over a 14-day period. Next slide, please. So we also have thresholds in these measures. There are 3 levels of thresholds for our daily case incidents, our outbreaks, and COVID-like illnesses presenting to the emergency rooms. And we also have 2 levels of measures for percent positivity in some of our hospital data. These have been developed using either national standards and or precedents that have been set, such as CDC guidance, and some of the goals that you may have heard the governor speaking to in terms of our goals for Virginia. Next slide. And so here I've pulled out measures for the Eastern region, and also below that, which you will not see on the public facing slide at this time, are Norfolk measures. So I wanted you to be able to see what is actually going on in our community. I want to pause here though and mention that it is important, even though we're thinking about Norfolk Public School, to think about this in the context of our entire region. I shared with you when we had the surge, this was something that was going on across our region. It may have started in one community and we saw it moving over to another. You all know how mobile we are within our region. Also, we may be a public school where most of our students live in Norfolk, but we have staff and they have parents who work and move between other areas of our region on a very regular basis. So we're all impacted by what happens in the region at large. So it's very important, particularly thinking about the teachers and other support staff working in the school, that they are living in the environment within the region, not necessarily just Norfolk. So I'll start with one of the first measures, and this is a measure, again, as you look at this, starting on the left, we're looking at incidence of disease. And so it gives us the number of cases. We have burden to the left, and to the right, in this entire area, you will see the trend. So for disease incidence of COVID, currently as a region, we are at 7.6, a rate of 7.6 per 100,000. And that puts us in what we call the moderate threshold category. And again, I mentioned that there are two thresholds set for this, one at 5. And so anything over 5 is considered moderate. Anything above 10 is considered high, and below 5 would be low. And what you see in the middle is the curve. And again, you can recognize approximately where we are by that dramatic peak, and that's when we experience the surge. But coming down to the far right, you can see we have come down due to the restrictions that were put in place, now back from high into the moderate category. And currently we are sitting at, I'm not able to see my numbers to the right, but I would say it's about 7, about midway between 5 and 10. You may be able to see those numbers. I can't see them right now. And similarly, well, actually, I guess 7.6. And then for Norfolk, looking a little bit, we're a little bit lower here. The incidence of cases was actually, and this is as of 9/29, at 5.6. And looking at the trends, I'll just go to Norfolk here. We are seeing a slight dip up. Can we back down a little bit? Okay, we're seeing a slight dip up here. So it has been increasing for the last 3 days, but so far we've not exceeded that threshold of moderate, and we're still in moderate range. So we only call a trend of increasing or decreasing if we see movement in one direction consecutively for 14 days. So next slide. Next slide, please. Okay, sorry. And here's percent positivity. And here the threshold is at 10%. And we are well below 10% at 4.7 for the region and for Norfolk City. Our trend in the region is decreasing. Our trend for the city is considered to be fluctuating, but again, we're seeing it sort of start moving upwards. So we're going to have to watch that very closely. That is a bit concerning, but we'll have to monitor that to see if that's an ongoing trend or just some fluctuation that we're seeing. Next slide, please. Here are outbreaks. We don't look at this graph so much for this one. Of course, we are investigating outbreaks, so we have a fairly good understanding of these, but the measure actually shows us below the threshold right now at 0.04 and 0.00, saying no outbreaks, but I know we have had some. The concern here is, again, those that are in congregate settings may be very difficult to deal with and do have potential adverse outcomes for those who are at high risk and impacted. Might add here too that we're going through these, we're looking at multiple measures, and I think it's very important to bear in mind that none of these measures are perfect. They're impacted by many things, such as outbreaks can affect our percent positivity and our case numbers. Who we test impacts our case rates. If we're not taking everyone, if we're screening only for people who are symptomatic, if we're broadly, people do not have access, all of that affects these numbers. So it's very important to think about many numbers together to confirm what we are seeing in terms of our metrics. Next slide. And healthcare workers, I won't go into in great detail for this discussion. I will mention that ED visits, when we were looking at the surge and asking questions about what we were seeing and what may be impacting this, was this really reflective of what was going on in the community? This was another indicator that we were really seeing rising transmission because we were seeing, as an early indicator, people were going to the emergency room in large numbers seeking help. ICU hospitalizations and deaths are important indicators, but they are delayed indicators. And when you start to see that, it's a little late then to be trying to intervene. You want to intervene much, much sooner than that. So emergency room visits, again, we are seeing it pretty much right on the border here. This is a regional measure again at 6.6, but moderate threshold. Next slide, please. And I won't speak of the hospital beds and PPE. I don't think those are terribly relevant today. Next slide. So weekly transmission extent. I want to talk a little bit about this one. Next slide. And so the weekly transmission is more of a composite score that overall gives us an idea of where we are in terms of community transmission. And as you can see, I've given you the composite for all of the regions in our state. And as you can see, Eastern region is at a moderate level of disease burden. Our trend is fluctuating and we're at moderate community transmission. We have 5 levels of transmission extent: substantial, and we have been there not too long ago, approaching substantial, moderate, fortunately we have come down, approaching moderate, and low community transmission. So we went from, prior to lifting of restrictions, being in this lower end of almost low community transmission up to substantial, and now coming down to moderate. Next slide, please. And here's a map of community transmission across the state. And again, you can see that we're in a moderate area. At the time we were experiencing our surge, we lit up as the only area in the region that was experiencing high community transmission. Next slide. And this, again, is kind of a quick dashboard measure. I call it a speedometer that points to where we are in terms of disease burden and trend. And you can watch this shift and move in terms of now we're kind of on currently as a region, sort of the lower end of moderate transmission, again, with a fluctuating trend. Next slide. Here, for those who may be interested, is an indication of how these are weighted. And the first metric, case incidence, as you can see, is very heavily weighted in that second column at 6. And then you have percent positivity, outbreaks, and hospitalization measures as being your other measures that are counted all in equal weights. Healthcare worker are not included in weighting these measures. Next slide. And now moving to our newer section, and this is CDC school metrics. So many of you are aware that the Centers for Disease Control recently came out with guidance on measures to consider in terms of making decisions regarding school openings. And they have recommended certain key areas be considered within their measures. And that is risk of transmission in schools. It looks at that derived from a combination of disease transmission indicators and also a self-assessment indicator. And there are 5 key mitigation strategies that they're recommending that schools consider in their self-assessment. And the question is, how well does the school system feel that they are able to institute measures around masking, social distancing, cleaning and disinfection, hand hygiene and respiratory etiquette, and contact tracing in partnership with the local health department. So the CDC framework is intended to assist states and localities in making decisions, but it is not a requirement. Also might add, when we look at the social distancing, this is based on cities' recommendations of at least 6 feet of distance between all parties. In the literature, there's some discussion about 3 feet being of consideration among children. But for these measures, if you're only able to maintain 3 feet, the measure should be considered not being met. Next slide. So this is a breakdown of the CDC indicators for decision making. The first indicator is the number of new cases per 100,000 within the last 14 days. And it breaks it down between low risk of transmission, lower risk of transmission, moderate risk, higher risk, and highest risk. And you can see that the ranges from less than 5, 5 to 20, 20 to 50, 50 to less than and equal to 200, and greater than 200 cases per 100,000 for the last 14 days. So that's a cumulative measure, whereas we were looking earlier at daily measures with the state indicators. And then percentage of positive PCR tests during the last 14 days. Again, with those percentages broken down, breaking them down into risk categories. And then the third consideration, and CDC recommends that you use 1 or 2 of these indicators. It has spoken a bit to the fact that no one indicator is perfect, so I would recommend you consider more than 1. And finally, the ability of the school to implement the key mitigation strategies. And these are the same strategies that we talk about over and over again in terms of how critical they are to control infection in our communities. Next slide. There are also some secondary indicators that are in the CDC recommendations. The first, the percentage change in new cases during the last 7 days compared to the previous 7 days. So here they're looking at trends similar to what we've discussed. Percentage of hospital inpatient beds in the region that are occupied, percentage of hospitalization beds in the region that are occupied by patients with COVID-19. And we do know that if our hospital capacity is stressed and patients are not able to seek hospital care or receive it, we will potentially see a rise in death rates in our community. So we never want to get to that point that we've exceeded our hospital capacity. And then the existence of localized community or public setting COVID-19 outbreaks. And these are not main category criteria. They are kind of that secondary criteria to be considered as you've considered the first ones and you're trying to make these decisions. This is additional information that you may want to take into consideration. Next slide, please. So now talking about the metrics, well, a little bit more here. This is how it looks on our pandemic website. And here again, I'm pointing out, you have the opportunity to sort of select the location that you are looking at. And so you can select Norfolk to look at Norfolk data. But again, a reminder, we encourage you not just to look at Norfolk, but also to look at surrounding communities as well in the region. Next slide. And here are the indicators just for Norfolk. And this is as of 9/28. Our total number of cases per 100,000 in the last 14 days has been 77.43. Understand from Dr. Birdsong, who's following this closely, we bumped up a little bit more as of today.
We have.
And that sort of puts us in the higher range in terms of this measure. And then the percentage of PCR tests that are positive within the last 14 days. We're still looking pretty good here at 4.2, although I did point out to you that we appear to be kind of trending upward in our percent positivity. And then the ability of the school to implement the 5 key mitigation strategies are something that you would know much better than I would in terms of what you know about the schools and what you know about your children and the community and the families, although I am going to raise some issues that I think are important considerations in these challenges. Next slide. So here are some secondary indicators though before we get there. And the first one here is the percent change in new cases during the last 7 days compared to the previous 7 days. And we're looking pretty good there. Again, looking at, this is their way of looking at trends. And then the percentage of hospital inpatient beds in the region that are occupied and the percent of hospital inpatient beds in the region that are occupied by patients with COVID-19. And because our rates are relatively low, we're looking pretty good in those as well. And then the existence of localized community public setting outbreaks, we're doing fairly well here, but it doesn't take but 1 or 2 for our measures to go up in that area. Next slide, please. And here, just to show you again another depiction from the actual dashboard site, you have the ability to select as an indicator whether you want to look at a 14-day case incidence, percent positivity, percent change, the hospitalization beds, occupied or occupied by COVID patients. Next slide. And then the map here, I guess I should have pointed out the map of where we are. Here is a region where we're trending higher than ideal. Next slide. And so I wanted to just kind of revisit the key differences between the VDH pandemic metric dashboard and the CDC school metrics. And just to point out that Virginia Department of Health has developed these metrics over time. It does take into account many of the recommendations for the Centers for Disease Control, but this CDC metric is quite new, and so they are not exactly the same in terms of how they're measured, the time, and the thresholds. So for the VDH pandemic metrics dashboard, you're looking at a daily case incidence rate. So you've got a daily rate on the curve, and then you've got a daily PCR percentage positivity, although each of those individual measures are 7-day moving averages. And then 3 thresholds as shown here. And then for the PCR positivity, 2 thresholds. For the CDC school metrics, instead of a daily case rate, it is a cumulative case rate over 14 days. And the same for the percent positivity. And you actually have multiple incidence thresholds and PCR positivity thresholds, many more than with the pandemic metrics. So there's a little bit of a balancing act in terms of aligning or comparing across the measures that we have in the dashboard to what you're seeing in the CDC recommendations. Next slide, please. And that's just definitions that you'll have. I'll move on to the next slide. And here is just kind of a suggested crosswalk to be able to translate these potentially into how they might be used. So again, here you see here the CDC transmission risk going from lowest to highest. And then we have the Virginia mitigation guidelines, phase 1, phase 2, and phase 3. Phase 1 is meant to sort of correspond at the highest level. And so at that level, you might consider remote learning as a primary approach. For moderate or higher, and these are just suggestions, it's still up to the school to decide where you want to go with these, but we would recommend a phased approach. At phase 2 would correspond to approximately the moderate and higher levels. Consideration there might be prioritization of which groups of students you would have for remote, for in-person learning versus virtual learning, restricting, not mixing classes, and eliminating or very strictly limiting any extracurricular activities. And then for the lower or lowest levels, that's when it may be safer to consider large numbers of in-person learning, but still discouraging large gatherings, maybe being able to offer more extracurricular activity. But I can't emphasize enough, those important preventive measures still apply. It is not schools out for recess for summer. You can do anything you want. Those measures are what helps continue to keep us safe. Next slide. So here's some considerations that I just wanted to raise. The metrics or guidelines are key starting points for informing decision making. we all recognize how important it is if we're able to safely get kids to return to school to do so. We want to prevent as much as possible COVID transmission and the adverse effects of that in our community. Yet we realize that there are benefits to children being in schools. Schools offer support and a safe harbor for children. In-person learning opportunities have values that remote does not. And so you have that hard job of balancing the risk and benefits between those two. I think it's very important to educate parents, staff, and community regarding expectations if schools are to be reopened. Schools are a reflection of the larger community. So most likely cases will occur if we have cases in the community. Our students live in the community, our staff lives in the community. Most likely when we see it in businesses, many cases, they brought it in from the community, the first case. Preventive measures are designed to reduce the impact and potential of transmission. And by preventive measures, I'm talking about those mitigation strategies that the Centers for Disease Control is asking you to assess whether or not they can be implemented and to what extent. There may be intermittent openings and closings of schools or a district due to cases, but it doesn't automatically mean just because there's a case that you got to shut the entire school down. And also a case or even several cases, if you're following the preventive strategies that have been discussed and doing the regular cleaning, does not mean that there has to be this extensive scrubbing of the entire school because there are one or two cases. The measures are designed, those recommendations, to reduce impact, and a more focused cleaning would be appropriate. And I think this one is critical. We're talking about what needs to happen in the schools, but again, schools are a reflection of the larger community. The safety of the children in school is also a product of safe choices at home and in the community. So families and households play a critical role in securing school safety by the choices they make in terms of adherence to preventive measures at home. Next slide. Considerations, cohorting students and staff as much as possible, as smaller classes as possible, keeping the same students together as much as possible. And I know that's a huge challenge, possibly for the higher grades, but at least for the lower grades, hopefully that can be done. Consider when you can rotating teachers instead of all the staff. So if you have a case, you have a small group of students that we're dealing with in terms of possible exposures, not all over the school with some complex case and contact investigation that we would have to do to determine who's at risk. Recommend tracking internal measures as well. Absenteeism of students and staff are important measures to follow for early detection of disease or issues. And it might not just be COVID, it might be the flu. They still need to stay at home. They still need to follow certain measures. And stress prevention everywhere throughout the school, as well as with parents, staff, in the community. And I've added one more, strongly encourage immunizations. If there's a time we need them, flu vaccines this year are critical. We know that you can have co-infection with flu and COVID. You can have one or the other. It may be hard to know initially which one we're dealing with, but all of those are stressor on the healthcare system, which we're dependent upon in helping us get out of this situation. So flu shots, critical. We look back at our influenza activity. I'm sorry I don't have that slide for you. Early this year, when the governor instituted the stay-at-home restrictions, and you could see an almost immediate and dramatic decline in flu cases as a result of those preventive measures. So that speaks to the importance of the preventive measures. But we know the most effective other measure is vaccination. And so really asking for your help in encouraging everyone to get their flu vaccine. Next slide. And I'm shifting gears on you a little bit, and this is to kind of talk about risk. And some of you may have seen this before. To your right, I'm talking about those things that create health, that determine whether or not individuals will be healthy. It has to do with environment. It has to do with people's ability to access resources, to be able to live a healthy life, education, job status, family support, income, those things. The physical environment in which each and every one of us lives, whether it's in a congregate setting, whether the environment supports health, whether or not that environment supports access to healthy foods and living, health behaviors, whether we choose to eat a healthy lifestyle, to eat or drink in excess, to exercise, and then access to health care. And we tend to think in our society about high tech, access to health care. You notice that only contributes 20% of health. A lot of it has to do with these other factors in our lives. And to the left, what I'm showing you here is a map of life expectancy of our residents in Norfolk based on where individuals live. The key here is depending upon where one lives, there's as much as a 15 to 20 year difference in life expectancy. And what can we all do with 20 more years of life? I mean, the choice is very obvious. You want to have that opportunity to live a healthy life. And these are the factors to the right that impact that. And that has to do with that graph being so disparate and not all of a similar color. Next slide. The reason I'm talking about that is that when we look at health issues in our community, we can look at that map and see how well it aligns with and predict where there are going to be issues of health in our community. And with any insult that comes to our community, now it's COVID-19, it may be something else, it is going to adversely impact those communities that are adversely affected on that graph with life expectancy, with health opportunity, essentially. So context is the perspective that ties this all together. Consider students and staff and how they may be impacted and what may impact their ability to follow recommended measures. And I'm pointing out here, 58% of Norfolk Public School students are African American. I started off early on talking about our COVID measures and showing you the disproportionate number affecting African Americans and the disproportionate adverse outcomes. The majority of the students are African American. 11% of students are Hispanic, of a Hispanic ethnicity. 63% qualify for free and reduced lunch. So that speaks to also issues of transportation. We can't say that you just tell kids not to ride the bus. That may be the only way of getting to school. And there's so many other factors in terms of being able to follow these recommendations that are tied with many of these factors. 14% of students are enrolled in special education, and these are students for many of them, in-person learning may be critical. Staff, consider the risk level of teachers and support staff. I understand a lot of your teachers are very young, but support staff maybe not so much. And I suspect that many of them may have chronic health issues, maybe of age where they may be at higher risk. Plan for staff safety, and what are you going to do if you have large absenteeism among your staff? and you don't have the capacity to continue whatever your program or plan is for in-person learning. Many Norfolk Public School families face challenges that may place a household member in a higher risk category. So we have children in the care of grandparents or multi-generational households. So mentioned, we have high African American populations. We have Hispanic populations that may be at greater risk. Life expectancies I talked about that may put people at higher risk for adverse outcomes, and transportation and other issues, as I was talking about, determinative health needs that impact outcomes. So these factors, we talked about what the CDC recommends for consideration, but these are also factors that may come into play as you're looking at prioritization, appropriate strategies for different phases, and how to adjust those based on your ability to effectively apply mitigation strategies. Next slide. So that's it. I'm open for any questions or comments that you may have. If you want to send me back for more homework, I'm happy to do that as well. Again, I thank you for this opportunity. You do a critical job. Really very appreciative of what you do for the children of Norfolk, and the health department is here to help in any way that we can. Thank you.
Thank you, Dr. Lindsay. We certainly appreciate you being here with us this afternoon. Dr. Martin, would you like to receive questions, feedback from the board at this time?
Don't see her, but
She might be frozen.
Yeah, looks like she might be frozen.
yes, Dr. Birdsong.
Thank you, Mr. Jordan.
Yes. So I saw that Ms. Campson had her hand raised. So, oh, there's Dr. Martin there. Anyway, go ahead, Ms. Campson, while we get Dr. Martin to be able to reconnect.
Thank you. Dr. Lindsay, has the CDC or any other group started collecting any data about looking at the differences between the K-12 programs that have gone full in school, or a hybrid model, or totally on virtual? Have we received, I mean, we watch what's happening in the colleges, but what's happening in the schools across the country that are making different decisions?
I'd like to look at that a little closer and get back to you with that information, but I'd be happy to look at that for you.
Thank you very much. I know it's still early, but I was hoping we'd get something as we start making, trying to decide what's best and safest for our children, and yet try and meet their needs when they really need some more in-school instruction. So thank you.
I will add that we do have some private schools that have already started in our area, and there might be some very valuable lessons learned and experiences there to share as well.
Okay, thank you.
Ms. Basine, you had your hand up?
Yeah, well, Dr. Lindsay, thank you so much for being here for the presentation today. One question, so regarding the hybrid model, as health conditions improve and allow us to consider, bringing students back in, I know myself and I've seen, other fellow epidemiologists, raise concern around the hybrid model in terms of greater opportunity for additional links in transmission because, they're in school for 2 days a week and then maybe in a childcare setting, and therefore really exposed to a greater number of students. Do you have those concerns, and is that a consideration that you think that school boards should consider in their planning for in-person learning?
I would say that what I'd seen early on was the hybrid model was recommended or suggested to address the issue of capacity, because it might be very difficult for some schools to be able to meet the social distancing and other measures such as cohorting without looking at considering some model like that. I think if you are aware that in this school community, those are the options that people would be using, it is certainly something worth taking into consideration. I don't know that I know enough about within our school system whether children are, for the most part, staying at home and learning at home, or what proportion are in daycare settings, and whether or not those are settings where, as the health department, they may be permitted, and we may have had some input into how those operations are being run. I think there are lots of different factors that might come into play there. I will ask, though, at the state level and also other districts as to what they've seen or experienced. But my immediate feeling is there are a lot of unknowns there that I'm not sure that I can speak well to without it having a little bit more knowledge of what's happening to kids while they're out of school.
Right. Okay. Thank you.
Mr. Clanton, go ahead.
Thanks, Dr. Martin. Dr. Lindsay, I'm not quite sure if I saw it in the presentation. Thank you, first and foremost, for making the presentation and providing this information. One of the things that I'm still, I don't know if it's in this, but I know that we've seen what you presented, but about ventilation. I know that there's been CDC guidance and information that's gone out about the transmission, and particularly about the concerns around ventilation. And I know that there's maybe different types of filters. And, when we talk about the average age of our schools, how does all of that translate into considerations about how we take next steps?
I would say first and foremost, those mitigation measures we talked about are key. Mm-hmm. And then when you get down to, the social distancing and a number of those things, the size of the room and the capacity of how many students you have in a room may be another consideration. But in looking at actual ventilation in the schools, I would defer to one of the engineers who are involved in school to actually be able to look at the measures, how the system is set up, and the capabilities. One recommendation is, if there are some concerns, when weather permits, having windows open and as much circulation going on as possible. But I think you would really kind of need an engineering assessment of what the ventilation is in the schools and how well it is meeting the recommended standards in that area. But again, capacity is another important issue.
Capacity is a major issue, but you would also agree that ventilation is also one of those things that's important, that also has to be taken into consideration in any plan, reopening, hybrid, or anything else, correct?
I would say that it's an important measure to look at, but again, the top measures are those key mitigation strategies that CDC recommends.
Great, thank you.
Mr. Jordan, go ahead.
I was going to yield to Dr. Gabriel if she wanted to go.
Oh, I'm sorry, I didn't see her hand. Dr. Gabriel, would you like to go ahead?
No, Mr. Jordan can go ahead. Go ahead.
All right, thank you. Thank you, Dr. Lindsay, for the presentation. I really appreciated your almost next to the last slide dealing with the life expectancy and the other factors. At least for me, it seemed to take us from just looking at the social construct of race to these other factors. As you all are looking at cases in Norfolk, has there been any mapping or any geospatial analysis to see whether or not we were having case clusters that, have we done any geospatial analysis of our cases?
We have periodically looked at where our cases are. But again, I would say that from what we've seen, the geographic pattern is not as telling as these other factors that I was speaking to. The risk groups kind of are the groups that are at risk because of some complication that puts them at risk, or another factor might be congregate settings, as well as occupations that are forward facing, where people are encountering large numbers of people and may not be able to mask. So that's been one that's been a little bit more difficult to get at, that occupational issue. But for the most part, from what I've seen, it really kind of goes back to those risk factors more than strictly geography.
Thank you.
Dr. Gabriel, go ahead.
Sure. Thank you also, Dr. Lindsay. Very informative presentation. This is my life every day almost. I wanted to just say first and foremost that you're not a stranger to Norfolk Public Schools. You serve on our Student Health Advisory Committee, and we appreciate your services on that committee. And I know that you have been in close conversation and contact with Dr. Birdsong and her administration throughout this entire process. And I'm very grateful that you're here to share with us and with our community and those that are watching, because they are very concerned about how the school board and the administration is preparing through data analysis on how we are going to safely bring students and staff members back in. I really do appreciate the question that Ms. Campson asked regarding following the data on other schools that have opened. And I would just say that as much as we can learn from our neighboring communities that are looking back at reentry, both from a private school and a public school setting, to watch their data closely. I know that, you know, as a practitioner, what we are seeing when the private schools went back is, I mean, we are seeing certain viruses pop up high, and I know our hospitals are keeping track of those viruses. Thankfully, COVID is, you know, going down, or the coronavirus is going down, but I would definitely appreciate the information on that. Can you speak a little bit to the ongoing relationship that you have with Norfolk Public Schools and the collaboration that you have established with our administration, so that the guidance that you are providing with them?
Well, first of all, I'm very appreciative of the relationship. It has been a strongly positive one. We feel that it's an important one and a critical one. My relationship with Norfolk Public School dates back to my time in Norfolk as a health director. Not very good with years, but I'll say it dates back to H1N1. That's when I started the last pandemic. And at that time, the health department was actually responsible for supervising school nurses in the school system. I came to, I thought I appreciated schools, but I gained an even stronger appreciation at that time because of that really close linkage and working together on that issue, and appreciating kind of from the inside the health experiences in the school system and the challenges there. Since in recently, I would say that it has continued to be a very strong and positive relationship. Dr. Birdsong and I have been in very frequent communication, and I guess you wouldn't mind my sharing that it is not limited to an 8 to 5 schedule. It is whenever the need arises. We often have conversations and meetings, and have had ongoing discussions since this COVID epidemic has begun. We recently, as the metrics have evolved, have started having meetings to kind of share and discuss this new data as it's evolved, looking at the potential benefit to the schools. We are also engaged, as with any other infectious disease, if there is a case or an issue or an outbreak, we are in direct and I would say almost immediate consultation with the school system regarding what is going on there. If there were cases among students in the public school system, then we would be directly involved in supporting with case investigation and contact tracing. And that would be, because you do know the students, there would be a partnership in that, but we would have a significant role in that. So it is, again, a relationship that I think is critical to our community. It's one that we value very strongly, and we intend to do everything that we can to continue to support that relationship.
We certainly appreciate it. Even before schools were shut down, we were in contact with Dr. Lindsay and her staff. So it's been just invaluable just to have them to advise us, to share information with us. And I could not imagine doing this work without Dr. Lindsay and her team.
Ms. Basine, go ahead.
I'm on mute. Emphasis would you put on, the fact that we have, certain events coming up in the coming weeks and months, whether it be Halloween, Thanksgiving, the holidays, which we know we can expect, to pose some potential risk for seeing some increase in COVID cases. Like you said earlier, it's all about our behaviors. But how much emphasis would you place on that in the decision making? I think she. Oh.
I think it's very important that I appreciate you bringing that question up, because I think it's very important in this type of forum that we remind parents and families of how critical this is. The one thing that I wanted to get across in today was the fact that the decisions we're making in terms of choices do have a direct effect on what our community transmission levels look like and how safely our children can return to school. I don't know that I can directly answer you in terms of how much you should look at that in terms of making a decision, but I would strongly support or encourage us encouraging parents and the community to really make that connection and think about any activities that may tend to drive our transmission rates up, affecting whether or not our children have this opportunity to have the in-person best quality education we can provide. And that means maybe we have to make some sacrifices right now. It doesn't mean we can't have fun, but maybe Halloween becomes a scavenger hunt at home, or safely distanced scavenger hunt through the neighborhood, or looking at other creative ways of celebrating without going door to door. So door to door would be the highest risk. If you must, then we are happy to provide you with the recommendations that the Virginia Department of Health has made in terms of how to reduce that risk from low to moderate to high. I'd like to see most people do low risk activities, and those low risk activities involve things that will not bring people together in crowds, not that direct face-to-face interaction and observing social distancing. And we have some very creative students in schools, and we have very creative people in the communities. There are many ways that perhaps we can celebrate more safely than going and knocking on doors of strangers to pick up candy. So rather than say, let's use this measure to decide whether or not we open schools, I'd like to focus on appealing to parents and neighbors and family and community to think about our children and think about what we can do to keep driving our rates down. I showed you those curves starting to appearing to sort of start to slant up. We don't want that to happen. We want to keep driving those rates down so we can keep our levels low as possible to keep our children safe and also keep the staff who have to be there to teach and care for them safe as well.
Thank you.
Anyone else? Any more questions? Okay, thank you, Dr. Lindsay. I really appreciate you've been so generous with your time to come and present with us this evening and to entertain our questions. The information in your presentation is definitely valuable as we make some very important decisions moving forward. And I look forward to working with you throughout the process. But I just want to say thank you again for being with us tonight.
Thank you, and I'll be sure to come back to you with the additional information that you've asked for.
Okay. Dr. Birdsong, did you want to say something?
I was thanking Dr.
Okay.
Thank you, Dr. Birdsong.
Thank you.
Yes, thank you, Dr. Birdsong, for setting this up for us.
And I appreciate Dr. Lindsay's flexibility. So again, thank you. I know you're juggling a million things, but we appreciate your time this evening.
I know you all are as well, so.
Thank you.
Okay, the next item on the agenda is for us to move into our executive closed session. So that will require a vote. Before we go to that, I sent a link to our executive closed session earlier today. Is there anyone who has not received that link? I'm not sure. I think I can see everyone. Everyone's good? Okay. Then can I get a motion to enter into the executive closed session?
Madam Chair, I move that we enter into the closed session.
Second.
Okay. Mr. Clanton made the motion and Ms. Smith seconded.
Okay. Move that members of the school board go into a closed session for the purposes which are set out in subsection A of subsection 2.2-711 of the Virginia Freedom of Information Act as amended for discussion or consideration of prospective candidates for employment, assignment, appointment, promotion, performance, demotion, salaries, disciplining, or resignation of specific officers, appointees, or employees of the Norfolk Public Schools pursuant to subsection 1 of the above cited code section. The subjects of this portion of the session are the discussion of today's regular personnel agenda and discussion of the superintendent's contract. Also, discussion or consideration of disciplinary and any other matters concerning students in Norfolk Public Schools that would involve the disclosure of information contained in the scholastic record pursuant to subsection 2 of the above cited code section. The subject of the section of the session is regular student support services agenda, and then consultation with legal counsel and briefing by staff members concerning actual or probable litigation or specific legal matters requiring the provision of legal advice by counsel pursuant to sections 7 and 8 of the above cited code section. The subject of this section of the motion are the two set out in subsection Freedom of Information Act requirements banking records.
I didn't hear the last part of the motion. I don't know if everyone else did.
Yeah, there's a weird noise coming through.
Okay. Oh, okay. You want me to start back with C? Okay, C, consultation with legal counsel and briefing by staff members concerning actual or probable litigation or specific legal matters requiring the provision of legal advice by counsel pursuant to subsections 7 and 8 of the above cited code section. The subjects of this section of the motion are the two set out in subsections B and C above the Freedom of Information Act requirements concerning COVID-19 records in the possession of public school divisions. Basine,
Aye.
Campson,
Aye.
Clanton,
Aye.
Gabriel,
Aye.
Jordan,
Aye.
Smith,
Aye.
Martin.
Aye. So the ayes have it, and we will disappear into the executive closed session and we'll return shortly.